Yes, good morning again. Now another topic, echocardiographic right heart catheterization. Right heart catheterization is an invasive hemodynamic procedure that directly measures the cardiac pressures and calculate the cardiac output. Now, with the help of right heart catheterization, we measure these hemodynamic parameters and normal values are also mentioned here. So what are the parameters? Mean right RA pressure, then right ventricular systolic and diastolic pressure, then pulmonary artery systolic and diastolic pressure, mean pulmonary artery pressure and pulmonary capillary wedge pressure. So we will see one by one how to measure this with the help of echocardiography. With the help of echo as well as cath, we can also derive these parameters by certain calculations. Now, almost all the parameters we can measure with the help of echocardiography. The first one is RA pressure. RA pressure we can measure with the help of inferior vena cava. IVC diameter should be measured in subcostal long axis view at end expiration just proximal to the junction of hepatic veins which is usually within 3 cm proximal to the junction of IVC with the right atrium. The change in the diameter of the IVC with SNP and also with quiet respiration should be measured. If the size of IVC is less than 2.1 cm and collapse is more than 50%, then the RA pressure is 3 mm of mercury. If IVC is more than 2.1 cm and collapse is less than 50%, the RA pressure is 15 mm of mercury. And if only one parameter is abnormal, then the RA pressure is 8 mm of mercury. Now, this scheme is less reliable for the intermediate values of RA pressure. So, for that, we should utilize additional parameters. These are the additional parameters. And diastolic flow prominence in hepatic veins indicates that the RA pressure is high. Normally, we have a systolic dominance in the hepatic venous flow, but the diastolic dominance with a systolic filling fraction less than 55% indicate that the RA pressure is high. Now, India, most of our patients have body surface area less than 1.6 square centimeter. So, my observation is that in India, we should take 1.7 centimeter as cutoff value for the IVC. And this paper also supports this. If a patient is some patient is large, body surface area is more than 1.6, then we can take 2.1 as the cutoff value. But in most of the Indian patients, 1.7 centimeters is the right value. Now here are few examples. Here IVC is collapsed, so this indicates a low volume status. Now here the IVC is normal sized and it is collapsing more than 50%, so this is a normal subject. Here IVC is dilated, it is about 20 mm and collapse is less than 50%. So here the RA pressure is about 15 mm of mercury. Here also IVC is dilated and there is no collapse at all. So again here the RA pressure is about 15 mm of mercury. Now patients who are on positive pressure ventilation, the degree of IVC collapse cannot be used to estimate the RA pressure. And here central line should be used if available to measure the RA pressure. But even in these patients, if IVC diameter is less than 12 mm, it indicates that the RA pressure is less than 10 mm of mercury. And if IVC is small and collapse, this suggests hypovolemia even in the patients who are on positive pressure ventilation. Now the next parameter to be measured is pulmonary artery systolic pressure. The right ventricular systolic pressure can be reliably determined from the peak TR gradient and adding RA pressure to it. And the RV systolic pressure is equal to the PA systolic pressure in absence of pulmonary stenosis. Technically adequate signals with well-defined borders can be obtained in majority of the patients. The recommended Doppler speed is 100 mm per second. The velocity measurements are angle dependent. So we should try to obtain the signals from various views like 4-chamber, the tricuspid inflow view, the short axis view, and even in some patients subcostal view. And we should use the signal with highest velocity. And if the signals are weak, they may be enhanced with the help of agitated contrast saline. And only well-defined dense signals should be measured. It is said that we should look for the chin, not the beard. The normal values for the TR gradient, it should be less than 35 to 36 millimeter of mercury, but this value increases with age. So we should keep this in mind. In older age groups, the normal values are higher. In patients with very severe TR, the Doppler envelope may be cut off because of early equalization of RV and RA pressures, and we may underestimate the TR gradient. Now, determination of pulmonary artery systolic pressure by TR gradient has been established as a reliable method since its publication in 1984 and found to have good correlation with cath studies. And it has been proven by other studies also. Here we can see that the gradients measured in the cath lab are almost equal to the echo gradients. But some studies have questioned the accuracy of this relationship, particularly at higher PA pressure levels. Here we can see that there is a scattering at higher level of PA pressure. Then the next parameter to be measured is PA diastolic pressure. PA diastolic pressure can be estimated from the gradient of end diastolic pulmonary regurgitation jet and adding RA pressure to it. The normal values are 4 to 12 millimeter of mercury. Next parameter is mean PA pressure. Mean PA pressure can be estimated with several methods. First one is with the help of early PR gradient. Measure the early PR gradient and add the RA pressure to it. The other method is to use this formula, measure the peak systolic pressure, the diastolic pressure, and with the help of this formula we can determine the mean PA pressure. One more method is with the help of pulmonary acceleration time. Pulmonary acceleration time is measured from the onset of Q. Here they have measured it from here, but actually it is measured from onset of Q wave in the ECG to the onset of pulmonary flow peak velocity. If the acceleration time is more than 120 milliseconds, then this formula is used to measure the mean PA pressure, and if acceleration time is less than 120 milliseconds, this formula should be used to measure the mean PA pressure. Then one more recently introduced method is with the help of mean TR regurgitation jet. Measure the mean velocity of the TR regurgitation jet and add RA pressure to it. And this method has been validated by right heart catheterization also. And whenever possible, we should try to measure the mean PA pressure with many methods, several methods. And the recommendations are that the PA systolic pressure should be estimated and reported in all subjects with reliable tricuspid regurgitation jets. And in patients with pulmonary arterial hypertension or heart failure, an estimate of PA mean pressure from either the TR jet or from the PR jet should be reported. Now the next parameter is pulmonary vascular resistance. The pressure is a product of flow and resistance. So if pressure is elevated, it is either due to increased flow or due to increased resistance, or due to both of them. Now this peripheral vascular resistance plays a important role in transplant recipient patient regarding the eligibility. We can calculate the pulmonary vascular resistance with the help of tricuspid regurgitation peak velocity and VTI of RVOT by using this formula. For example, here the peak TR velocity is 2.78, the VTI of RVOT is 11 centimeter. If we keep it in this formula, the resistance is around 2.68 Woods unit. Abnormal pulmonary vascular resistance when the value is more than 3 Woods units. Now this relationship is not reliable in patients with very high pulmonary vascular resistance. If it is more than 8 Woods units, then this formula doesn't work. The recommendations are that the estimation of pulmonary vascular resistance by echo is not recommended for routine use. It may be considered in subjects in whom pulmonary systolic pressure appears to be exaggerated by high stroke volume, or it is misleadingly low due to reduced stroke volume. The non-invasive estimation of pulmonary vascular resistance should not be used as a substitute for invasive evaluation when it is important to guide the therapy. Now we can also measure the cardiac output and index. Cardiac output is nothing but stroke volume into heart rate, and cardiac index is cardiac output divided by the body surface area. Now we can measure the stroke volume with the help of by measuring the LVOT diameter and area and VTI of LVOT, and the machine automatically displays the stroke volume. Similarly, we can measure the stroke volume at the level of RVOT also, and in presence of shunts we can calculate the QP QS with the help of this. Now the next important parameter is pulmonary capillary wedge pressure. The early work suggested that E prime could be used reliably to estimate the LV filling pressure, which is equal to pulmonary capillary wedge pressure, and also the LA pressure. But later studies have shown greater scatter, and that is why the recent recommendation of American Society of Echocardiography recommends this flow chart to measure the LA pressure, which includes 4 parameters: the EA ratio, the average E to E prime ratio, TR velocity, and LA volume index. Now here are 2 patients. Here the EA ratio is more than 2.2. The E to E prime is 20.5, and there is diastolic prominence of pulmonary vein flow. So here the pulmonary capillary wedge pressure or LA pressure is significantly elevated. Now this is another patient. Here EA ratio is 1.4, the E to E prime is 8, and there is systolic dominance of pulmonary venous flow. So here the pulmonary capillary wedge pressure or LA pressure is low. So the right heart catheterization is gold standard. Gold is gold, and the ornaments made of gold are still beautiful, but they are not for daily use because there are some dangers associated with it. Now we have artificial jewelry, which is for daily use and which serves the purpose. So echo serves the purpose if we are interested in knowing the right-sided heart pressures. Thank you very much.